Welcome to the SNF Spotlight Series, your one-stop shop to find out what's really going on in SNFs nationwide. I'm your host, Yitz Rubin, and this is sponsored by Renewal Rehab, the best therapy provider for SNFs nationwide. So welcome. Thank you so much for joining the SNF Spotlight. You're the VP of Growth at Vitae.
Vitae Health Systems, and I'm the Vice President of Growth and Strategy.
Can you tell me a little bit about Vitae and what you guys do?
Yeah, so Vitae Health Systems is a provider of internal medicine and behavioral health services to skilled nursing facilities and some other types of facilities, supportive living, assisted living, et cetera, but all in the long-term care space. My background prior to coming to Vitae is in long-term care administration and SNF operations. And in my experience, most buildings operate the same way. You know, the buildings provide the floor staff, the CNAs, nurses, nurse management, and then you have physicians that provide the licensed clinician providing, where the prescribing services come through the doctor, through the nurse practitioner, through the physician assistant. And the coverage is kind of what the coverage is. You usually have doctors coming in once a week. Their mid-levels may be providing additional services when they're not in the building based on whatever it is that doctor's staffing model looks like. And the buildings receive what they receive from these doctors. Similar patterns are in place for the psychotherapy and behavioral health services that we currently provide. Prior to Vitae coming into a lot of homes, they'll have a psychologist or a licensed clinical social worker that rounds once a week, once every couple of weeks, working with the most at-risk patients in the building. But there are a lot of gaps in that coverage. And what Vitae does is aim to fill those gaps so that the buildings who are facing increased acuity and more difficult and clinically complex patients to deal with are also receiving additional services to help deal with that increased acuity. As a SNF operator, your reimbursements are your reimbursements. And while, sometimes they go up, sometimes they go down, there's not tremendous changes in them. You have your fixed per diem, and you need to find your staffing model with your CNAs and nurses to provide the best care that you can. But beyond that, you have to lean on your doctors or your high-level clinicians to provide oversight to your clinicians. And if a doctor is only rounding once a week, and that's what the building's used to, Vitae will come in there through its internal medicine programming and provide it, when appropriate, a nurse practitioner 5 days a week in your building. So that you're not just having a doctor round once a week and have his or her mid-level come in 1 or 2 times during the week as well, and then move on to the next building. You'll have RNP in a building 5 days a week, 8 hours a day, not just seeing patients, but being a part of your facility's team, working in your interdisciplinary meetings, in your policies and procedures, really becoming a part of your core clinical product. And a similar thing exists on the behavioral health service line. We'll provide psychotherapists on a more dedicated basis than buildings are typically used to receiving to help with their patients on the behavioral health front. Especially during COVID, with restricted visits and families not able to see their patients and people dealing with anxiety and depression in the SNF space, having a dedicated psychotherapist in a nursing home, helping these patients work through what's typically a difficult transition or just existence in general in a skilled nursing home really helps with outcomes and just client satisfaction for the nursing homes.
Yeah, so tell me what you're seeing. I mean, you have experience initially as an administrator for a while. What are you seeing in skilled nursing facilities as far as customer care and the metrics?
The continuum of care has holes, and to be frank, that's why Vitae, I think, has thrived and has been successful over the past few years, is because we're helping to fill in those gaps. When the type of patients now that the buildings are receiving, when they were in a hospital 5 years ago, would have had a doctor rounding 3 times a day during each shift. The buildings don't have those resources, but are now expected to take care of patients that were that acutely ill. So Vitae is able to fill in those gaps. And not only with these increased challenges do the buildings face a more difficult time caring for these patients, their referral sources and insurance providers are also demanding from them exceedingly better outcomes and care. And the buildings sometimes are, what are we supposed to do to really keep up with all these increased demands for better readmission rates, better patient outcomes, shorter length of stay? We're still getting what we're getting from the government. How do we help fill in these gaps? We can't really afford to sometimes. So our company comes in and tries to help them out with that.
So tell me a little bit about your background in healthcare as you climb the ranks.
I'm based out of Chicago, and I wasn't originally an administrator. I started as an administrator in training. in a nursing home here in Chicago in 2012, I believe. I started as an AIT, about a year in, became an administrator. At a certain point, transitioned from administration to business development, regional business development, and then regional director of operations for a company, Legacy Healthcare, in Illinois, and then was managing a portfolio of homes for them out on the West Coast. Prior to, in 2018, starting to work on coming together with Vitae, with a doctor that I knew and some other investors in the skilled nursing space. And then we started Vitae in late 2018.
Yeah, it's always interesting to see someone like move up the ranks, especially quickly, and start their own thing. So what has COVID been like for you?
COVID's been interesting, right? Like everybody's aware of the difficulties that the buildings themselves are facing. Everybody's aware of the patient population being susceptible to the virus. A lot of the doctors and providers that have been working historically with skilled nursing facilities, in the face of the pandemic, scaled back their coverage, went to telehealth, maybe refused to come into the building altogether. A lot of doctors that service nursing homes often are physicians at the tail end of their careers, getting out of clinic work, taking a more comfortable nursing home rounding position. And then the pandemic hits, and now they're afraid to go into the skilled nursing facilities. And it accelerated for a lot of buildings the need for additional coverage. While we've been doing internal medicine services in buildings since late 2018, our behavioral health division only started about 6 months prior to the pandemic, but our clinician roster has grown over 5 times what it was prior to the pandemic through the pandemic, because the buildings were more desperate for additional internal medicine support because their patients are sick and need additional monitoring, whether they have the coronavirus or not.
What innovations have you seen in this space recently?
I know some companies that we work with, there are medical director groups that have rose to the forefront with specific clinical policies and procedures and rounding to work with COVID patients. So that's somewhat of an innovation to deal with the struggles they were facing in the building with the pandemic and helping buildings better deal with COVID positive patients or preventing COVID from coming in altogether. But I don't know if I would categorize those as long-term innovations. They're COVID related. And so many of the buildings that we come into are buildings that are facing issues that, to be frank, like innovation isn't so much or wasn't so much during the pandemic at front of mind, so much so as survival was in getting through a pandemic. But for a lot of these homes, it's a matter of keeping staffing ratios up, keeping administration and nursing leadership in the buildings. It's a tough time for nursing homes in general. Well, listen, let me ask you this. I know you're interviewing me for the most part today, but you meet a ton of people. When you look at the trajectory of hospital systems, right? Hospital systems in the markets that I've been in, and some of them that we are in right now are still like this, but I'll focus in on the Illinois market, Chicago specifically. Hospitals 10 years ago, maybe even a little closer back than that, were open to community physicians who, if a doctor's patient who they've been seeing monthly or quarterly in the community went to the hospital for pneumonia or whatnot, they would go around in the hospital and manage that patient's care. But the hospital would have nurses and the CNAs or PCTs, whatever they're categorizing them as, on staff, similar to how the nursing homes do now. But hospitals, recognizing the need for more control of the clinical care in the building and more standardization of the care in the building, moved away from a community-based physician pool to a hospital-controlled physician pool. You're going to typically get a doctor that comes in there that works for the hospital in a full-time capacity. They're there in the hospital, probably assigned to that unit 4 or 5 days a week, and that's what they do. They might have a moonlighting job somewhere else, but they're employed by that hospital. Didn't used to be like that, but the hospitals moved everything in-house, and now they don't even allow these outside physicians for the most part to round in there. Almost no nursing home across the country directly employs or even indirectly employs or manages the doctors in their home. These are typically doctors that are rounding at 6 or 7 other nursing homes, doing whatever they'd like, and the buildings are receiving the care from the doctor at the doctor's will, and however the doctor wants to administer it. Whereas a company like Vitae and other companies are doing something similar in the physician space, are giving, in some capacity, the different ways to do this, are giving facilities dedicated or more dedicated providers so that it isn't as much like the hospital space as it was. So you're closing the gaps and differences in the different clinicians and different services you're receiving from your doctors and other ancillary or specialty physicians, and you're making it a more controlled environment. And by bringing it all into a cohesive clinical continuum of care, you end up with better practices and more cohesion, and everybody's operating more along lines the same page towards the same goals, which is not the case in most nursing homes right now.
Does this also help give another revenue stream for the nursing homes?
Yes and no. There's more revenue in it for the nursing homes and more revenue available if you do a better job clinically. So on a specific patient level, if you're thinking about whether this patient will provide more additional revenue to the home if they're receiving better services, yes, because that patient's less likely to readmit to the hospital, and you're therefore not losing nights with that patient in your building. Whether it be a long-term or a short-term patient, when that patient's out of the home at midnight, that's no longer your patient, and that reimbursement goes to the hospital or wherever that patient went to. So that's a direct way where better clinical care will give you more revenue per patient stay, so to speak. But additionally, because the hospitals are promoting better clinical care to be more viable as a referral source for these hospitals, if you're not improving and finding ways to be more attractive to the hospital systems, who very often are at risk with the insurance providers for the care, meaning that if the patient receives good care in the nursing home, the hospital makes more money. And if they receive poor care in the nursing home, they may lose money on that patient. You then become a more attractive destination for the hospital, and they're more likely to have their patients admit to you just based on a clinical value proposition that you offer to that hospital more than anybody else in your area, any of your competition, which then makes you more viable financially because you're better at generating admissions.
Right. So it's not so much as the like MedB that the nursing homes would be able to get reimbursed as a MedB, like an outside practice. It's more of just better clinical results. Is that what I'm getting?
Yeah, I mean, I'm not sure what you're referencing from the MedB perspective. I know that's primarily who, therapy may bill to on long-term populations. I know physician practices are typically billing through MedB. I don't know exactly the ins and outs of what you're getting at, but I know from just a general revenue perspective, holding on to your patients and making sure that they're not readmitting to the hospital gives you more nights with that patient as opposed to losing those to the hospital. And better care generates more and better referrals for your nursing home, which then makes you more successful. Census is what drives revenue for the most part.
Right.
So.
Yeah, thank you so much, Isaac. It was very, very informative. It seems like you guys are doing great work. Keep up the great work and keep helping seniors.
That's what we're here for, helping the space, helping the buildings, and helping the patients. And everything we do hits all the above, we think. So
yeah,
keep on moving forward.
Thank you for sharing this tremendously important part of senior care. The SNF Spotlight Series highlights healthcare heroes and thought leaders in the skilled nursing community. We're building awareness, trust, and shining the light on SNFs. So stay tuned. Remember to like, comment, and share.